नमस्ते एभ्रिवान। आज चाहिँ म नेशनल लेप्रोसी एलिमिनेसन प्रोग्रामको बारेमा चाहिँ वाचन गर्न गइरहेको छु। यो चाहिँ मैले लेटेस्ट एनुअल रिपोर्ट लिएको छु जुन चाहिँ 78-79 को रहेको छ। नेशनल लेप्रोसी एलिमिनेसन प्रोग्राम बैकग्राउंड। Leprosy, also known as a Hansen disease, is an infectious disease caused by Mycobacterium leprae, an acid-fast rod-shaped bacillus. Leprosy is an old-age disease described in the literature of ancient civilization. It is likely transmitted by droplet from the nose and mouth during prolonged and close contact with untreated leprosy patient. The disease mainly affects skin, the peripheral nerve, mucosa of upper respiratory tract, and the eyes. Leprosy is curable, and early diagnosis and treatment in the early stage can prevent disability. The establishment of Kokna Leprosarium in the 19th century was the beginning of organized leprosy preventive services in Nepal. The government of Nepal, in collaboration with WHO, conducted a leprosy survey in 1960 with an estimated number of 1 lakh leprosy cases. Dapsone immunotherapy was started as a pilot project in 1966 in Nepal. The project gradually expanded as a vertical program and remained so till 1987, when it was integrated into general health services. Multi-drug therapy was introduced for the first time in Nepal in the year 1982-83 in selected fused area and hospital. By that time, the number of registered cases has come down to 31,537. Prevalence rate of 21 per 10,000. The number of districts then with a prevalence rate of over 5 was 62, and in only 3 districts the prevalence rate was less than 1 per 10,000. There was a gradually and steady expansion of MDT services, and by 1996 MDT coverage was extended to all the 75 districts of the country. Being a member country, Nepal is committed to elimination of leprosy in line with the global program and is an active member of Global Alliance for Elimination of Leprosy. It's a public health problem. A 6-year plan was developed in 1995 for strengthening the program. Accordingly, as per the plan, an estimation of leprosy prevalence was done and all basic health services were provided. Training in leprosy health education was intensified to improve community awareness and to facilitate case detection. The first independent evaluation of National Leprosy Control Program was undertaken during January 1996 by a group of experts representing His Majesty Government, HMG, WHO, and national government organization NGOs. 2 rounds of leprosy elimination campaign were organized in the year 1999 and 2000. Following the continuous effort from the Government of Nepal, Ministry of Health and Population Leprosy Control Program, WHO Nepal, District Health, Public Health Office and concerned agency, leprosy was eliminated as a public health problem at the national level in 2009 and declared in January 19, 2010 with a national register prevalence rate of 0.77 cases per 1,000 population, which was below the cutoff point of below 1 per 10,000 population, definition set by WHO. Milestone of Nepal National Leprosy Elimination Program of Nepal. Year landmark. In 1960, leprosy survey by Government of Nepal in collaboration with WHO. In 1966, pilot project to control leprosy launched with Dapsone immunotherapy. In 1982, introduction of multi-drug therapy in leprosy control program. In 1987, integration of vertical leprosy control into general basic health services. In 1991, National Leprosy Elimination goal set. In 1995, focal person TB leprosy assistant appointed for district and region. In 1996, all 75 districts were brought into MDT program. In 1999, 2000 and 2001, 2 rounds of National Leprosy Elimination campaign implemented. 2008, intensive effort made for achieving elimination at national level. 2009 and 10, leprosy elimination achieved and declared at national level. 2011 develop and endorse national leprosy strategy 2011 to 15. 2012-13 elimination sustained at national level and national guideline 2013-70 revised. I'll go to in 2013-14 midterm evaluation of implementation of national leprosy strategy 2011 to 2015. 2014-15 Ministry of Health designated leprosy control division as a disability focal unit. 2015-2018 piloting of leprosy post exposure prophylaxis in Japa, Morang and Persa. 2017 policy strategy and 10-year action plan on disability management, prevention, treatment and rehabilitation 2073 to 82 developed and disseminated. 2018 national leprosy strategy 2016 to 20 2073 to 77 developed and endorsed. Revised leprosy guideline in line with the national leprosy strategy and global leprosy strategy. 2019 in-depth review of national leprosy program and envisioning a roadmap to zero leprosy. 2020 deployment of leprosy post exposure prophylaxis guideline. 2021 endorsements of national roadmap for zero leprosy Nepal 2021 to 30. Endorsement of national leprosy strategy and action plan of Nepal 2021 to 25. Deployment of leprosy training package for medical officer and basic health care workers. Goal, objective, strategy and target of national leprosy elimination program. The national leprosy elimination program of Nepal is guided by national roadmap for zero leprosy 2021 to 30 and national leprosy strategy 2021 to 25. The vision, goal, objective, target of national leprosy elimination program is stated in national leprosy strategy of Nepal 2021 to 2025. Vision, leprosy free Nepal. Goal, elimination of leprosy, interruption of transmission of leprosy at the subnational level. Municipality, interruption of transmission is defined as zero new autochthonous child leprosy cases for consecutive 5 years at municipality level. Objective, to eliminate leprosy transmission at subnational level, province, district, local level. To strengthen clinical case management at district and municipality level and improve referral system. To enhance capacity building through training of health staff, particularly at peripheral health facility. To enhance prevention of leprosy, reduction of stigma and discrimination. To strengthen leprosy surveillance system and regular monitoring, supervision and periodic evaluation at all levels. To strengthen partnership among different stakeholders. To strengthen management of leprosy complications like reaction and disability prevention and rehabilitation. To coordinate with neighboring state of India in management, reporting and referral of cases from broader area. To promote research and innovation. Target of national leprosy strategy. Target 1. Mapping of district municipality including human resources. Baseline 2019. Inline 2025. Updated. Target 2. Number of municipalities with zero new child autochthonous cases over consecutive 5-year period 605 to 700 is the inline year. Target 3. Number of municipalities with zero leprosy cases 65 to 377. Target 4. Number of annual new leprosy cases reduced to 3,282 to 2,462, 25% reduction from baseline. Target 5. Rate of new leprosy cases with grade 2 disability per million population 5.3 to less than 1. Target 6. New child leprosy case detection rate per million child population 30 to less than 6. Target 7. Number of child cases among new leprosy cases reduced to 260, 7.9% child cases proportion among new leprosy cases to 52% child cases proportion among new leprosy cases. Target 8. Number of child grade 2 disability among new child leprosy cases 2 of 260 new child cases to 0. Target 9. Discriminatory law. Discriminatory law exists. Zero discrimination is a result of no discriminatory law and compliant reporting system in place. Target 10. Roll out of preventive chemo prophylaxis. 50% coverage among eligible contact. Target 11. Household contact examination of an index case within 3 months of case detection. 75% of index cases. 2019 in taken as a baseline because the impact of COVID-19 pandemic on leprosy cases diagnosis and treatment. For baseline only 1 year of data of 2019 is taken due to unavailability of municipality level data on the past 5 years. A strategic pillar with key component. Pillar 1. Implement the National Leprosy Roadmap for Zero Leprosy across all level, nation, province and local. 1. Political commitment with adequate resources for leprosy elimination at all levels in an integrated approach. National Partnership for Zero Leprosy and Zero Leprosy Roadmap engaging all stakeholders. Capacity building in the healthcare system for quality services. Improve program management, surveillance, monitoring and evaluation system. Promote operational research. Pillar 2. Scale up leprosy prevention alongside integrated active case detection. Active contact tracing for all new cases, especially household contact. Preventive chemotherapy, scale up through chemoprophylaxis. Integrated active case finding in targeted endemic hotspots population. Pillar 3. Manage leprosy and its complication and prevent new disability. Early case detection, accurate diagnosis and prompt treatment. Access to comprehensive well-organized referral facilities. Early diagnosis and management of leprosy reaction, neuritis and disabilities by improving capacity through training. Monitoring, support and training in self-care. Mental well-being through psychological first aid and therapeutic counseling. Monitoring of antimicrobial resistant, adverse drug reaction and adverse drug events. Pillar 4. Combat stigma and ensure human rights are respected. Adoption of principle of and guideline for elimination of discrimination against person affected by leprosy and their family member. Inclusion of organization and network of person affected by leprosy at all levels. Abolishment of discriminatory law. Develop system to monitor stigma reduction in communities and villages and cities. Access to social support rehabilitation with coordination with government agency and NGO. Leprosy program monitoring key indicator. Monitoring is a consecutive part of National Leprosy Elimination Program. Routine monitoring is a principal and essential component in assessing the progress of National Leprosy Elimination Program and is vital for proper management. National Leprosy Elimination Program has identified the following indicator for routine monitoring. Province, population, new case detection rate per lakh population, prevalence rate per 10,000 population, MB proportion among new, child proportion among new, proportion of grade 2 disability among new, proportion of grade 2 disability child among new, and female proportion among new. National. The national new case detection rate NCDR per 1 lakh population was 7.81 and prevalence rate per 10,000 population was 0.81. Highest NCDR new case detection rate and prevalence rate both were observed in Madhya province, followed by the Lumini province. Almost 3/4, 72.7% of new cases were MB cases. The child proportion among new cases was 3.19%. 7.44% were found to have grade 2 disability, and the proportion of female among new cases was 43.3% in fiscal year 2078-79. The key achievement in the management of leprosy. DHS incorporated the key data from health facilities. PHCORC report only 2 variables that include number of follow-up of regular cases and number of referral for suspected cases, and there is no any recording reporting from the FCSBs. The new leprosy case detection. The detection of new cases signifies ongoing transmission with the rate measured per 1 lakh male population. A total of 2,285 new leprosy cases were detected in fiscal year 2017-79, with the highest new cases 910 in Madhya province, 40% of total cases. Meanwhile, Karnali province has the lowest cases new case detection with 68% cases 3%. A new case detection rate for fiscal year 2017-79 was 7.8 per lakh population nationally. Among the new cases, 72.7% were multi-bacillary cases. Province-wise new leprosy cases and new case detection rate fiscal year 78-79. You can see total in national 2,285. and new case detection rate is 7.8, highest in Madhya province and second highest in Lumbini province and lowest in Bagmati province. Distribution of new leprosy cases 2078-79. Madhya province 910, 40% of total cases. 13 district Sangkhla, Pastor, Bhojpur, Khaldunga, Sulukhumbu, Khotang, Ilam, Rasuwa, Ramesap, Kabri, Humla, Monang and Magdi reported 0 new cases this fiscal year. Prevalence at the end of fiscal year 2017-79, 2,373 leprosy cases were receiving MDT in Nepal, which make a registered prevalence rate of 0.81 cases per 10,000 population at a national level. This rate is below the cutoff point of 1 cases per 10,000 population set by WHO to indicate the leprosy elimination of leprosy is a public health problem. This also shows that Nepal's elimination status is a public health problem from 2009 is being sustained. The prevalence rate has increased slightly than the of previous year because of increased field level activity and active case detection. Out of 77 districts, 7 districts reported 0 prevalence, 54 districts has a prevalence less than 1 and 16 districts has a rate of more than 1. Baki, you can see name of district having prevalence rate more than 1. Baki, Sarlai, Chapa, Bardia, Mautari, Dhanasa, Morang, Sira, Kailali, Rupandi, Kapilvastu, Rautort, Persa, Otsam, Naurprasi and Bara 2.09. Distribution of registered cases and prevalence rate in 2078-79. Province wise, we can see total cases 2,373 and prevalence rate 0.81. 0 prevalence, you can see here in green zone. Prevalence rate less than 1 in yellow zone and rate prevalence rate equal or greater than 1. District with prevalence rate greater than 1, 16 district Chapa, Morang, Sidaha, Dhanasa, Mautari, Sarlai, Rautahot, Bara, Persa, Rupandi, Parasi, Baki, Bardia, Kailali, Kanchanpur and Assam. District wise leprosy burden. The highest number of leprosy cases under treatment was reported from Madhya province, 878 cases, 37% of total, and lowest Karnali province, 84 cases, 3.5% of total cases. The registered prevalence rate was the highest in Madhya province, 1.43 cases per 10,000 population, followed by Lumbini province, 1.12 per 10,000, and lowest prevalence was reported in Bagmati province, 0.1 cases per 10,000 population. 16 out of 77 districts reported prevalence rate more than 1 per 10,000 population in fiscal year 2078-79. Trend in disability, child and female cases. Leprosy cases that are not detected early on may result in disabilities. Early cases, timely and complete treatment of leprosy are crucial factor for preventing disability. The proportion of grade 2 disability among new cases and the rate per